So welcome to Making Life Easier with Assess, Prepare, Treat of Wound Infection. So we're going to take you through the Coloplast three-step approach today of Assess, Prepare, Treat of wound infection specifically. As I said, if you've got any questions throughout, please just pop them in the chat as we go, and Sam will answer them for you. So our objectives today is to introduce you to the Coloplast three-step approach, which is a really simple, easy, step-by-step framework that will help you to effectively assess, prepare and treat infected wounds and wounds with biofilm. Now, what we're planning to talk about is and to help you learn a simplified approach to wound healing today. Now, the Coloplast three-step approach, as I said, is that simple, easy, step-by-step framework, and that should really help you to simplify your approach to wound healing. You should understand the impact of wound infection and biofilms, because we know that wound infection can be difficult to treat sometimes. You're going to gain an overview of the latest principles of the best practice from the International Wound Infection Institute. And then at the end, you will leave with the Coloplast three-step approach wound infection pathway to support your practice. Now, you will be getting a certificate emailed out to you once the webinar is completed, and that will also have the Coloplast three-step approach wound infection pathway as well. So there is a huge burden of wounds within the NHS, and Guest did some work in 2012, 2013, and then again in 2017 and 18. So 3.8 million patients with a wound are managed by the NHS annually. So that is an awful lot of patients that have wounds that you are all managing. The annual cost of managing those wounds that healed was estimated to be £2.7 billion, but compare that with the 5.6 billion for the 30% of wounds that did not heal. So as you can see from that, it's just over double the amount to treat wounds with an infection compared to those that we managed to heal. So it's estimated that 59% of chronic wounds heal if there's no evidence of infection, but you can compare that with 45% if there was a definite or suspected infection. So chronic wounds we know are difficult to heal anyway, but if you add on the difficulty or the complication of having a definite or a suspected infection, then it makes it even more difficult to manage. The prevalence of biofilm in chronic wounds may be greater than 80%, and actually it's likely that 100% of chronic wounds will contain biofilm. And 46% of healthcare professionals believe that infection is a challenge when treating wounds. Now, I'm a tissue viability nurse specialist by background, and I know how challenging it can be to treat wounds with infection. So hopefully after today, we'll be able to simplify that process for you, and it will make it easier for you. So, of course, there's clinical relevance of wound infection, and it is a common wound complication, but it's often difficult to identify. So, as we said on the previous slide, 80 to 100% of chronic wounds will contain a biofilm. So all of our open wounds are contaminated with microorganisms or bacteria. So wound infection occurs when those microorganisms, they move deeper into that wound tissue and they proliferate, they multiply, leading to local and or systemic immune responses. And the host's immune system and the species of the bacteria will influence that development of wound infection. So it can depend, on the type of bacteria in that wound and how good the host's immune system is. Now, often patients that have got chronic wounds or wounds that are hard to heal often have lots of comorbidities, and therefore their immune system might not be what it once was, and therefore the bacteria can take over, and it might be more difficult with patients that have got difficulties with their immune systems. So in the event of an infection, wound healing is delayed. And I'm sure you've all seen patients that have got hard to heal wounds that seem to be static, and it doesn't seem to matter what you're doing. It doesn't seem to get any better. But hopefully throughout today's presentation, you will see some of the steps that you can take to move those wounds that are hard to heal towards that healing trajectory. The patient's quality of life can be adversely impacted. So patients that have got a wound infection, the wound can be more smelly, the exudate can increase, and therefore the dressings probably need to be changed more frequently. So for patients going to the GP surgery, that means more visits. For patients that are nursed in their own home, that means more community visits. And we know that from the work that Guest did, the expensive part of wound care is yourselves, is the healthcare professional. The dressings and the things that we use only equate to 6% of that massive amount of money that we're using. Your treatment costs rise because we know that antimicrobial dressings are more expensive, and your wound management practices become more resource demanding, as I just said, more GP surgery visits, more community nurse visits, or wherever it is the patients are being looked after. But the hope is with a holistic approach, proper assessment and early intervention, many problems can be avoided and the clinical outcomes can be improved. And hopefully you'll see that throughout today's presentation. So this is the Coloplast 3-step approach to simplifying wound healing. 3 simple steps to follow when you are looking at a patient with a wound. So step 1 is your assessment. An assessment is paramount in defining those treatment objectives. So you have to do a full holistic assessment of your patient, a really robust assessment of your patient. Think about their comorbidities. What else is going on for that patient? What's their mobility like? Are they managing to eat and drink? Are they undernourished or are they overnourished? What services do they need to help them to live their day-to-day lives? And before you even look at the wound itself, you do that full holistic assessment of your patient. You then break it down and look at your wound, also that hole in the patient. And we have the Triangle of Wound Assessment, which is a holistic framework that allows practitioners to assess and manage all areas of the wound, including that peri-wound skin. So it's vital that you look at the wound bed, the wound edge, and that peri-wound skin. If the peri-wound skin is unhealthy, it's unlikely that we're going to be able to improve the wound healing for that wound. So we need to make sure that we're looking at all 3 aspects of that wound. Once you've done a really robust holistic assessment of your patient and of their wound, you'd move on to step 2, which is prepare. And wound preparation is key to removing those barriers to healing. It helps to create that optimum healing environment. And wound preparation is probably the hidden gem in wound care. It's something that over the years we haven't, there've been mixed messages around not disturbing the wound bed, not cleansing the wound bed, but we know now, and the evidence is there to support that we really must do robust wound preparation to remove those barriers to healing, to removing that debris, to reducing those biofilms. And once you've done step 2, prepare, you may well go back to your step 1 and reassess that wound, because you might have removed some of those barriers to healing. You might have removed some of that slough or devitalized tissue, and you might have a better idea of what's going on with that wound. And then you move on to step 3, which is your treat. So that's your portfolio of dressings to manage a wound of any depth and stage of healing. And we will go through this in more in depth as we go through today's webinar. So step 1, your assessment, the aims of your wound assessment. Now you really need to identify the cause of that skin breakdown. It could be that this wound has started as a bite, or somebody has knocked their leg in the garden, but 3-4 weeks down the line, that wound is still not healing. And actually you need to be thinking about whether there is some underlying vascular complication here. And is this wound actually now a venous leg ulcer? You need to identify those associated risk factors, and you will be able to do this when you do your full holistic assessment, looking at your patient's comorbidities, what their nutritional status is like, what their mobility is like. That will really help you to identify those associated risk factors and then help you put in place to try and reduce those risk factors. It will help you to correct or treat any underlying cause. So if we think about a patient that maybe has diabetes and isn't managing their blood sugars very well, we know that patients with diabetes are at an increased risk of developing wound infection. And if their blood sugars are high, they're going to be at more of an increased risk of developing infection. So we need to understand why their blood sugars aren't being well controlled and help them manage those. That will, as I say, help you identify those appropriate management options. It will help you to control wound-related symptoms. So if you have got lots of wound exudate, if you've got an odour with that wound, if the exudate is purulent, thick and pussy, it can help you to control those symptoms. Can prevent further skin or wound deterioration. You need to identify your patient's expectations. Now, I'm not sure about you, but you always get asked the question, how long is this going to take to heal? My answer is it's different for everybody. Everybody will heal at different rates. So it's really difficult to put a figure on how quickly we can get that patient to heal. But what we do need to verbalise is that we will do everything possible in our power to support that patient and their wound to heal. And you need to provide that psychosocial support and promote the patient independence. So it's really important from the off to have conversations about supported self-management. Now, supported self-management doesn't mean that the patient has to do everything themselves. It could be that they're able to remove their dressing and have a shower before the nurse visits, or it could be that they're able to apply their moisturisers and their emollients to their surrounding skin before the nurse visits. So think about how you can get your patients involved with their care. Frequency of wound assessment will really depend on the condition of your patient and the condition of the wound and the care setting that they're in. So a holistic wound assessment should be, as a minimum, every 2 weeks in the acute setting and every 4 weeks with a primary care and community setting. And the difference between those is, in the acute setting, people generally tend to be acutely unwell, and as they get the treatment that they need, their condition improves. So they will need more frequent holistic assessments. Generally, your patients in that are looked after in the community tend to be, and I say this tentatively, more stable. I know patients are very complex, but their condition doesn't generally change as quickly as it might do in the acute setting, and that's why we say every 4 weeks within primary care and community settings. Of course, if your patient's condition does change, then you will need to do another assessment of that patient. So it's really important that we look and listen. We need to use those senses when we're doing our assessment. So your listening is really about taking that history of your patient and actively listen to what they are saying to you. They know themselves and their conditions best. So I'd identify those factors that may delay healing. Talk to the patient about any concerns, and this will really help you build that rapport with your patient. If they see that you're actively listening to what they're saying and understanding the problems that they're finding, then it will help with that rapport building. You need to know what medications your patients are on, because patients may well be prescribed medication that they're not actually taking. So you need to know what medications they're prescribed, what they're taking, what dosage they're taking, and if they're not taking any of their prescribed medications, you need to understand why. You need to look at your patient, so look at their age, their body weight. And with their body weight, we often focus on patients that are undernourished, but think about your patients that are overnourished too, because they're not getting the diet that they should be getting. It's probably not a balanced diet that they are getting. So you need to think about your undernourished and your overnourished patients. Think about your patient's mobility, their general demeanour. Are they anxious? Are they tired? Are they confused? Is their confusion caused by an infection? Is that infection coming from the wound? Look at your clinical observations, so your blood pressure, your pulse rate, your oxygen saturations. They're all really important things that we need to make sure that we do with our patients that have got a wound. Look at the previous dressing. Your previous dressing can tell you an awful lot. So it's really important that if patients are removing their own dressings before you arrive, that they keep that dressing for you to have a look at. You need to do a top to toe skin assessment, because that will help to confirm or reject any differential diagnosis or treatment plans. And it helps you to understand what condition that patient's skin is in, not just around that wound bed, that wound edge and that peri-wound skin, but their overall skin condition. So things that you need to look for when you do that skin assessment is skin dryness and dehydration. We know that as patients get older, their skin dehydrates, it becomes more dry. But you also need to think about the opposite end of that, and is moisture and maceration, and what is causing that. Could it be exudate from the wound, or could it be incontinence, and are we managing that incontinence appropriately? You need to do pulses to see whether they're present or absent. So think about your patients with leg ulcers. We need to know what the blood flow is like in that lower limb. We need to know about their pain. Are they getting pain all of the time? Or is it only when your dressing changes? Has that pain increased? So it's really important to speak to the patients about their pain and what they're taking for that pain and whether that's being managed well. Think about the patient's temperature. Is there any inflammation? Is there any infection or non-blanching erythema if you're looking at your pressure ulcers? Is there any ischemia to that area? Or is there any deep tissue injury? And then think about skin sensitivity, so numbness, burning or tingling around that area or within that limb. Odour is really undervalued during skin assessment, and it can provide useful information about that skin condition, but you must, of course, use it sensitively. So odour can reveal several things, which includes poor personal hygiene, incontinence, both urine and feces. So we had a patient that we looked after, bilateral leg ulcers, and every time this patient came to see us, the bandages were soaking wet with urine. Now, we spent months with this patient trying to sort of highlight the issues with incontinence and how we could help, but this patient just wasn't accepting that it was actually urine that was soaking his bandages. Think about your wound exudate. Smell can really help with that. Wound infection. So if there's been an increase in your exudate, if there's been an increase in pain, if there's been an increase in odour, it could be that you're looking at wound infection for these patients. Necrosis and slough can cause an odour in that wound, and that highlights we need to do really good wound preparation to remove those devitalised tissues. And also malignancy can cause an odour. But it also can really affect the patient. So we had another patient that used to come and see me at the GP surgery, and they used to go out once a week to meet their friends in a cafe. Now, unfortunately, this patient ended up with an infection in their leg ulcer, and it was quite smelly because of that infection. And on one of the visits to the cafe with their friends, they were actually asked to leave because of the smell of coming from their wound. Now, how embarrassing is that for your patients? For my patient, they were absolutely mortified and stopped going out to meet their friends. And so that has that knock-on effect for their mental health as well. So really think about how the odour can affect your patients. Now, this is our triangle of wound assessment in Coloplast. So this helps you. I like this because we have the circle around the patient. Now, that identifies your holistic assessment, your whole patient, before you then look at that hole in your patient. And when you do look at your wound, you break it down to the wound bed, wound edge, and that peri-wound skin. And again, this is a simple, easy framework to help you assess and manage all aspects of that wound and of that patient. And it's like the Coloplast 3-step approach, broken down into 3 separate areas. We like the rule of 3s, nice and easy to remember in Coloplast. So your Coloplast 3-step approach of assess, prepare, treat, and your wound bed, wound edge, and your peri-wound skin is your triangle of wound assessment. So your wound bed assessment will help you assess what tissue type, exudate, and whether there's any potential infection in that wound bed, edge, and peri-wound skin. Now, your tissue types that you will probably see within your wounds are necrotic. So these can be black, dark brown in colour. They can be hard. They can be quite soggy to touch. Sloughy tissue tends to be yellow, can be a little bit greeny. It can be quite tough. And again, it can be quite loose to be able to remove it. Now, your granulation tissue, this is your pink or reddy coloured tissue in your wound beds. This is what we want to see in our wound bed, granulation tissue. but you also need to be mindful if the granulation tissue is quite dark or purple in colour, bleeds really easily, that can be a sign of wound infection. Your epithelialization, so this is when your epithelial cells start to migrate across your wound. So this is when you're starting to move towards that wound healing and trajectory, and this is really where we want our wounds to be. So that granulation tissue and then those epithelial cells start to migrate across that wound bed and close that wound eventually. Now, your exudate, you really need to think about how you document this. So the volume could be dry, it could be low, medium or high. Try and describe what it is that you're seeing rather than just writing plus, 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 plus. It's very subjective, I know, with exudate, but it's really important that people understand what it is that you've seen. Think about the consistency. Is it thin and watery and is it clear, or is it thick, purulent exudate that's like pus? Is it clear and cloudy? Is it clear, cloudy, purulent, pink, red? That can really help you understand a little bit more about what's going on with that exudate. If it's pink or red, you know that there's perhaps been some bleed in there. If it's purulent, thick and cloudy, it could be that there's some wound infection going on there. And your local signs of infection are that increased pain, your erythema, your edema, so your swelling, that local warmth around that wound edge, increased exudate, delayed healing, your friable granulation tissue, so that's when that granulation tissue bleeds really easily or bleeds without you having to touch it, any malodor or pocketing. Now your spreading systemic infection is that increased erythema, so you see that spreading redness around that wound edge, pyrexia, so a temperature, abscess and pus formation. Could be wound breakdown, likely would be wound breakdown. You could see cellulitis. Your patient might be feeling generally unwell. Could be coldy, flu-y type symptoms, but they can't put their finger on why. You could have a raised white blood cell count and lymphangitis as well with your spreading infection. Your wound edge assessment, so this helps you look for any maceration, dehydration, undermining, or those thickened rolled edges. So maceration at your wound edge will cause problems for your epithelial cells because it makes them more difficult to migrate across that wound bed if that macerated tissue is really wet and boggy at that wound edge. It probably means that when the dressings that we're using aren't managing that exudate appropriately, so we need to reassess the treatment objectives for that patient. Dehydration is a problem. Again, for your epithelial cells like a nice moist wound bed environment. Think about it as an ice rink because your epithelial cells need to be able to skate across that wound bed to close that wound. If it's dry and dehydrated, then what you'll find is it's like trying to skate across a muddy field, really difficult. So we need to remove any of the dehydrated edges. We need to think about, again, our treatment objectives and make sure that that wound bed edge is moist to help with that wound healing. Your undermining, you'll tend to see this with your patients that have got hard to heal chronic wounds, long-standing wounds, and it can be really difficult with your undermining edges to be able to get those wounds to heal. And your rolled edges, again, you'll tend to see in wounds that are chronic in their nature, and these patients may need to have surgery to remove that rolled edges and sort of give us a fresh, clean edge to start again. Your peri-wound assessment, so this will look at, again, maceration, excoriation, dry skin, hyperkeratosis, callus, and your eczema. And all of these problems on your peri-wound skin will not help with your wound healing of that wound bed and wound edge. So you need to make sure that you have a really nice, healthy peri-wound skin to help with that wound healing environment. Now, your maceration, as you can see here, this is likely, again, due to the fact that the dressing that's been in place has not managed that exudate appropriately. So the dressing won't have conformed down into that wound bed. What's happened here is there's probably an exudate pooling, and that pooling has then spilled out onto that peri-wound skin and macerated it. Your excoriation can be caused by dressings if the patient has any sort of reaction to that. As you can see on this wound here, is perfect for that sort of where that wound dressing has been sitting. It makes it really dry and itchy for that patient, and then you get stuck in that itch scratch cycle. If patients start scratching their dry skin, they can break it, bacteria can harbour, and then you can increase that patient's risk of infection. Your hyperkeratosis, I'm sure all of you have probably seen hyperkeratotic legs. And I don't know about you, but used to spend ages sitting and picking at hyperkeratosis. Good wound preparation will help with hyperkeratosis and helping to improve that peri-wound skin. Callus you generally tend to see on patients with diabetic foot ulcers, so that callus needs to be removed. It's basically devitalized tissue. There is no blood supply getting to that area, so it becomes dry and hard, so we need to remove that callus. And then eczema can also be a problem with that itch scratch cycle, can also be a symptom of your patients that have got venous deficiencies. So who is at risk of wound infection? Well, absolutely anybody is at risk of developing a wound infection. It's multifactorial and it occurs when the cumulative risk factors overwhelm that host defense. So that host defense is no longer able to fight it off and manage. Factors that will debilitate the patient, impair their immune response or reduce tissue perfusion, increase that risk of infection. So the individual risk factors are poorly controlled diabetes, as we discussed earlier, medications, conditions associated with hypoxia or poor tissue perfusion. So think about your patients that have got venous insufficiencies, think about your patients that have COPD, etc. They're not going to be getting that oxygenated blood around that body as well as they need to be. Think about inappropriate antibiotic prophylaxis. So there's a big thing in the NHS about not using antibiotics if they're not appropriate. And hopefully today, going through wound infection with you will help you see that we don't always need to go straight to an antibiotic, an oral antibiotic. We can use an antimicrobial dressing to manage local infection. Your protein, energy, malnutrition, and your alcohol, smoking, and drug abuse, of course, will increase that risk. And then your environmental factors, hospitalization, unhygienic environments, which I'm sure for those of you that work out in the community have seen several unhygienic environments. Poor hygiene and aseptic technique, really difficult to carry out full aseptic technique in a patient's own home. And definitely in some of the homes that you go in, you would rather shower as soon as you leave that environment. So really difficult sometimes. Inadequate pressure offloading, repeated trauma. So this could be your inappropriate dressing removal. So dressings such as biotin silicone can be left in place up to 7 days. If it doesn't need changing within those 7 days, leave it for that 7-day period. Sometimes we can get tied into, we must see these patients twice a week, 3 times a week. In actual fact, we don't need to be. And then your inadequate management of moisture, exudate and oedema. And as we saw at the wound edge and the peri-wound skin, if our dressing isn't able to manage that exudate, then it can cause maceration in those areas, harbours bacteria, and then you increase that risk of infection for your patients. So wound characteristics which predispose us to infection. In acute wounds, think about your trauma with delayed treatment. So as I said earlier, it could be a patient that's knocked their leg, been trying to manage it at home on their own with a plaster, with some Savlon cream, or whatever it is that the patients are trying to use. And by the time that you actually see that patient, there is an ongoing infection in that wound. Chronic wounds, think about your size and depth and whereabouts they're sited. So think about your patients with pressure ulcers, perhaps, that are near their sacral area or across the buttocks. Patients may be incontinent of urine or feces. It's difficult to keep those areas clean. And then things that are risk factors for both is your necrotic tissue or foreign bodies. The necrotic tissue, the bacteria like to hide beneath that, so we can't get to them. That's why we need to do good wound preparation. Impaired tissue perfusion, hematomas, and increased exudate or moisture, which we've been through. So this is your wound infection continuum, and all wounds will sit on this wound infection continuum. Okay, so we're going to go through the different stages in the wound infection. So your local, you have your contamination and your colonization. Now these do not cause the host a problem. So your wounds, as we said already, all wounds that are chronic or difficult, hard to heal, will be contaminated with bacteria. But colonization and contamination don't generally cause a problem to the host defense, so our immune system can manage with them. It's when you get to local infection that we start to get a problem. So this is when your microorganisms, your bacteria, like to multiply, and they move deeper into that wound bed, and they deeper into those tissues, and they cause that host response. And now that response is localized in one location, system, or structure. So thinking of your wound, you will get some redness around that wound edge and that peri-wound skin. That is your localized response. Your microorganisms in that wound are multiplying, and the signs and symptoms are subtle but may develop into classic symptoms of infection. Now, this is just a review of the subtle symptoms, so hypergranulation or overgranulation, bleeding, epithelial bridging or pocketing, wound breakdown, delayed healing, increased malodor or pain. And your classic symptoms are your erythema, your redness, your heat, your swelling or your edema, purulent discharge, so like pussy type discharge, delayed wound healing, pain and malodor. Your spreading infection, this is where the bacteria or those microorganisms are present within that wound and are proliferating, they're multiplying and invading those surrounding tissues. Now, the patient will show subtle as well as classic signs of infection here, but they may also start to develop early systemic infection indicators. And then your systemic infection, so this is where the wound, the infection from that wound starts to affect the body as a whole. So those microorganisms are spreading throughout the body via that vascular or lymphatic system. And this is when you're thinking about sepsis with your systemic infections. And the signs and symptoms are your sepsis, your organ dysfunction, and your systemic inflammatory response. So you are really concerned about your patients at this point. Now, your biofilm tends to sit between local infection and systemic infection, and it's a structured community of microorganisms or bacteria with a genetic diversity that creates chronic infection. Now, the easiest way to describe biofilms is an army, and this army have got shields or umbrellas, whichever way you want to think about them, that they can hold up. So they're an army, there's lots of them together, and then they have their shields that gives them that extra protection. They're not visible to the eye, but signs of infection indicate presence of biofilms. And with a biofilm, what we need to do is knock some of them shields off, get down to the actual little army itself and try and remove some of them. And how you'll do that is by good assessment, really good wound preparation, and then making sure that your treatment is in line with your objectives for your assessment. Now, microorganisms in the wound, Pseudomonas, I'm sure you've all seen Pseudomonas. It's a gram-negative microorganism, and it's believed to reside in the deep wound tissues and is a keen biofilm former. Now, 52.2% of chronic leg ulcers contain Pseudomonas, and those wounds are characterized by larger sizes and slower healing rates. Now, Pseudomonas produces this pigmentation, which aids in that visual detection through that green discoloration. Now, it can be a really lovely colour of green, and I'm sure you have all seen it, but obviously not great for our patients. You usually smell Pseudomonas before you see it. And then you've got your Staphylococcus aureus, otherwise known as MRSA. It's a gram-positive bacteria, it's a prominent human pathogen, it's a keen biofilm former, and it can range from minor self-limiting skin to invasive life-threatening infections. Now, 30% of all healthy individuals will carry Staphylococcus aureus in the nose without any awareness or impact. But one of our well-known types is MRSA, and it still has continuing mortality rates of 28 to 38%. Now, I'd like to think we're much better at managing MRSA. We swab, don't we, everybody for MRSA, but we're still seeing patients die from MRSA. 28 to 38% is quite high. So when do you make a microbiological analysis? So when do you swab basically your wounds? So any wound, any acute wound with classic symptoms of infection, chronic wounds with signs of spreading or systemic infection, Infected wounds that have failed to respond to antimicrobial treatment or are worsening despite antimicrobial treatment, in compliance with your local protocols, and wounds where the presence of certain species would negate a surgical procedure. So beta hemolytic streptococci in wounds prior to skin grafting. If patients carry this type of bacteria, the skin graft won't take. So we need to be able to remove that before they have the skin grafting. Now, please make sure that you follow your local policies and protocols for wound swabbing. This is a generalised idea of when you should and shouldn't swab, but of course you will have your own local policies and procedures. Now, we've done a thorough holistic assessment of our patient, and we've assessed using the triangle of wound assessment of our wound edge, wound edge, and that peri-wound skin. We're now going to move on to wound step 2, which is our prepare. Can't get my teeth in today. So wound preparation, slough, non-viable tissue and biofilms can all delay that wound healing process because they can increase that risk of infection. They can inhibit that development of healthy tissue, and they can limit that wound assessment. Now, if you've got a wound that is full of devitalized tissue, you don't actually know what's going on in the wound bed because you can't see it. And that means that we can't, that healthy tissue can't develop because it's been it's limited. So we need to make sure that we remove all of that. Now, 80% of our non-healing wounds contain biofilm, as I said earlier, and actually it's 80 to 100% of non-healing wounds will contain that biofilm. So we need to try and reduce these risks of infection, and try and remove any of those things that are going to reduce that risk of healing in that wound bed. So it's clinically proven that cleansing and debridement speeds up wound healing. Now, this is taken from a study, a Wilcox study, which was done in 2013, and this looked at just over 310,000 patients and the frequency of debridement. Now, this part here that you can see, the median time to heal for diabetic foot ulcers was around between 50 and 60,000 patients with a diabetic foot ulcer. And as you can see here, if you debrided or cleansed and debrided that wound once every 2 weeks, the median time to heal was 76 days. If you debrided and cleansed that wound once a week, that is reduced to 21 days. So it will heal 3 times quicker with wound preparation. And there's actually, I would argue that you should be doing wound preparation every time you see that patient to change their wound dressing. It's only going to do good things for that wound and speed up that wound healing process. Now, holistic assessment directs wound preparation. That includes washing, cleansing and debridement. Now, there are, of course, different types of debridement. Washing and cleansing doesn't require any extended competencies and training. Autolytic debridement, so this is when the body attempts to shed the devitalized tissue by the use of moisture. So we can help that with the treatment and ensuring that we maintain that moist wound healing environment. So this could be through the use of dressings. Mechanical debridement, so this is the physical removal of devitalized tissue using friction. So a long time ago, we'd use the wet to dry. So we'd use wet gauze, place it on the wound, leave it to dry and then pull it off. Your patient would be on the ceiling in absolute agony, but you would have removed some of that devitalized tissue, as well as probably causing some trauma. We now have lovely debridement pads, such as the AllPrep pad, to help us with mechanical debridement. And this doesn't require extended competencies and training, but does require some knowledge and skill. Biological debridement, so this is your use of larvae and maggots. And of course, these are sterile larvae and maggots, although I'm sure lots of you have seen homegrown maggots. As a tissue viability nurse in the acute, I was called down to ED one day with the referral that the patient's feet looked a bit strange. And when I got down to resus, this patient's feet definitely did look strange because his toes, all of them on both feet, were moving. I have never seen so many homegrown maggots on one patient. And, you know, that they say to drown them. These were super maggots. They went into the bucket and they swam to the edge of the bucket, climbed up them when we're jumping left, right and centre around ED. So think about your homegrown, there will be opportunistic flies for you, those of you that are looking at after patients out in the community. But sterile larvae and maggots in their little tea bags are wonderful little things that are applied to the wound bed, and they digest the devitalized and dead tissue, and they will only digest the devitalized and dead tissue. Brilliant at what they do, but they can be quite an expensive treatment. Enzymatic debridement, so this is ointment, gels or dressings containing enzymes that soften and lift that necrotic tissue. Do need to be careful when you use an enzymatic debridement, because if you get any of it on healthy skin, it can cause burns. And then of course you have your sharp or conservative sharp surgical debridement. So this is when a healthcare professional that has extended skill and competency will use a scalpel, forceps, curette or scissors to remove devitalized tissue. Now, please, I cannot stress this enough. You can only use conservative sharp debridement, sharp or surgical debridement if you have been trained to do so. And there are training courses that you go on to learn how to do this. So please don't all start wielding a knife. Stick to your mechanical debridement pads unless you have had this, this extended skill and competency. So there are best practice recommendations for the management of biofilms and infection. The first recommendation is wound preparation. So cleanse and debride the wound to reduce the number of microorganisms by disturbing and removing some of those biofilms. So this is where something like your all prep pad would come into play. By disrupting those biofilms. Remember, I said they had shields, disrupting some of those shields, getting rid of some of those shields and getting down to the actual biofilm itself and removing some of that bacteria. Step 2 is to apply a barrier dressing, and step 3 is around your infection management. So this is where your infection continuum comes in, and you would use an antimicrobial dressing for your wounds that go from infected to systemic infection and or have a biofilm. Okay. So how often will preparation be required? So if we take you back to the wound, to the Wilcox study that we just discussed, you need to think about how frequently you want to debride, prepare your wounds, and that will depend on your clinical knowledge and assessment of your patient. But more frequently, if you're changing your patient's dressing because it needs to be changed twice a week, I would suggest that you should be doing wound preparation twice a week on those patients. If you're only needing to change that patient's dressing once a week, then of course do wound preparation once a week. But the Wilcox study showed the more frequently we do wound preparation, the quicker we can get that wound to heal. So it will depend on your assessment, as I said, your clinical judgment, your treatment goals, and of course your patient's pain level. It might be that you need to work up to longer periods of preparation with your patients. So just make sure you have good open conversations with your patients when they're doing this. It could be also this is something that they help and support themselves with supported self-management. Sometimes we can do things a bit harder if we're doing it ourselves because we know where we can manage the pain. So think about your supported self-management with your wound preparation. Of course, there are going to be times that we need to be cautious with wound preparation. So if your patient's got a wound on their lower limb and is known to be diabetic, this may be suitable for wound preparation, but will require specialist advice. So this is where you need to get the advice of either the podiatrist or your tissue viability nurse specialists in your area. If a patient has a known arterial flow concern or poor localized tissue perfusion, if that area is dry, hard, necrotic tissue, then we might not want to try and prepare that wound if it is dry, hard necrosis and we know that there is arterial flow or poor localized tissue perfusion, because that area is not getting the blood supply that it needs. And if we then open it up, we are not only opening up at the risk of infection, but the likelihood is we might not be able to get that wound to heal because it hasn't got that blood supply that it needs. And then if patient have healing ability is impaired because of medications or underlying medical conditions, so your cytotoxic medication or your patients that are immunosuppressed, just think about whether their immune system is able to manage if we do the wound preparation. So it might be that you need to have a chat with their specialist if they're under specialist, or speak with your tissue viability nurse specialists. So we've done a holistic assessment of our patient and of our patient's wound. We've done really robust wound preparation. We're now going to talk about step 3, which is your treatment and your portfolio of dressings. So you really need to identify your treatment objectives, and doing that holistic wound assessment will help you do that. And when you've done your wound preparation, as I said earlier, you might then do another wound assessment, because you might have removed some of that devitalized tissue or some of that debris, and you might be able to have a better idea of what's going on at that wound bed. And the idea should be that we should always aim to support an optimum wound healing environment for that wound. So moist wound healing is the optimum healing environment for the majority of our cases. So as I just said in preparation and when to be cautious, think about your patients that have got vascular compromise, or if there's a blood supply deficiency in the area that you're trying to treat. So you do have to think about that. But on the whole, moist wound healing is what we're aiming for. So you need to think about what your treatment objective is. It could be for exudate or exudate pooling, and in which case you need to have a dressing that conforms down into that wound bed, and then that exudate needs to be absorbed vertically into that dressing and then locked away so that none of that bacteria is then put back into that wound bed. Think about the protection of the peri-wound skin. Could be maceration or excoriation that is a problem, so you need to manage that. Could be depth or cavity to that wound, or it could be your infection and biofilm. And remember that identifying and treatment of any underlying cause is integral to your wound healing, which you should have picked up in your wound assessment. So the international best practice for management of biofilms and infection, of course, step 1 is wound preparation, but step 2 is to apply a barrier dressing. Now, this will help prevent maceration by management of that exudate and prevent recontamination. So as you can see in this image here, this is a Biatain Silicone AG. So this is step 2 and step 3, because it's infection management and applying a barrier dressing. Now, the infection management, this Biatain Silicone AG contains silver, but it has a prolonged release throughout that wear time. So it's not all dumped into that wound as soon as you put it on. It's a prolonged release. As you can see in this dressing here, it's bubbled up, and that's where this dressing has conformed down into that wound bed. You can see that the exudate on the dressing is only where that wound is, and that's because with Biatain Silicone AG, the exudate is absorbed vertically and then it's locked away, and that bacteria is locked away in a lock-away layer. So when do we implement an antimicrobial dressing? Now, lots of people will think wound infection, straight away antibiotics. That is not the case. So with contamination and colonization, topical antimicrobial dressings aren't indicated because that bioburden is not causing clinical problems. The host is managing with its immune response to manage that. Local infection, you need to be using your topical antimicrobial dressings here. You do not need to go straight to antibiotics, oral antibiotics, when there is a local infection. It can be treated with antimicrobial dressings. Now, when you get to your spreading infection and your systemic infection, this is when you will need systemic antibiotics along with your topical antimicrobial dressings. And it's really important, if this wound has been the cause of this systemic or this spreading systemic infection, that you continue to treat your wound as well with your antimicrobial dressing. We can get fixated on managing that systemic infection and forgetting where this infection has actually come from. So it's really important to remember your wound and remember your antimicrobial dressings here, as well as your antibiotics. Now, topical antimicrobials are available in different forms. They come as liquids, pastes, creams, ointments, sprays, and impregnated dressings. And how you use them and the frequency of application will depend on that product. Some are used every day for a short period of time. Some require reapplication several times a day. So if you're using ointments or creams, it could be that you need to apply that several times a day to that infected area. And some are left in contact with the wound for several days. So think about your antimicrobial dressings that contain silver, such as your Biatain Silicone AG. Now, there are different types of antimicrobials that are used in wound management and have been used in wound management for a very, very long time, hundreds and thousands of years. And these come in the forms of honey, PHMB, iodine and silver. Now, your topical agents with silver have been used for thousands of years, as I've just said, to help prevent or to treat infection. Now, there is an international consensus for the appropriate use of silver dressings in wounds, and that was an expert working group consensus. Now, it's been available in the following forms, so solid, as a solution of silver salt used to clean wounds, and as a cream or ointment containing silver antibiotic compound. Now, do not think, please, that if you cover yourself in silver jewelry, that is going to reduce your risk of infection, because it doesn't work like that. It needs to be in a specific form to be able to work. So in recent years, a wide range of wound dressings containing silver has been developed that are far easier to apply, and they provide that sustained release of silver and need less frequent dressing changes. So some silver dressings used to just, when you put them on, would dump all their silver straight away. Dressings now, such as Biotane Silicon AG, have that prolonged release. So it's a sustained release whilst that is in contact with the wound bed. Silver has a really broad spectrum antimicrobial effect against bacteria, with both gram-negative and gram-positive bacteria. So your Staph aureus and your Pseudomonas. And silver has shown to prevent biofilm formation in vitro studies. And how does it work? So silver targets multiple sites in that bacteria. So what it does is it binds to that bacteria cell wall, blocking transport of substances in and out of that cell. So it engulfs that cell, it blocks it. Nothing can come in, nothing can come out. And then the silver ions are transported into that bacterial cell, where they block that respiratory system. So it not only binds to that cell wall, blocking things coming in and out, but it also suppresses that respiratory system of that cell, destroying its energy production. And then finally, it interacts with the DNA, and it stops that bacterial cell from multiplying. So 3 actions: binds to the cell wall, blocks that respiratory system, destroying the energy production, and then it stops that cell from multiplying. And that is how your silver works. Now, of course, we have the 2-week rule with antimicrobials, or the 2-week challenge, if you like. So this is to help with appropriate use of antimicrobials. You have seen that your wound has a local infection or a spreading and systemic infection. Therefore, you need to use, with your local infection, you need to use your antimicrobial dressing. With your spreading, oh, goodness me, what's going on with my teeth today? So with your local infection, you use your antimicrobial dressing. With your spreading infection or your systemic infection, you will use antibiotics along with an antimicrobial dressing. Or if you suspect biofilm with your wounds, you need to use an antimicrobial dressing. So the duration of antimicrobial use should be an individual assessment based on regular wound assessment. It has been suggested to use a 2-week challenge to determine the clinical efficacy of the silver dressing or the antimicrobial that you choose to use. And after this period, the wound, the patient, and the management approach can be re-evaluated according to the figure. So after 2 weeks, there's been some improvement, but continuing signs of infection, you will continue with that silver dressing with regular review. If you've seen improvement and there's no longer any signs of infection, that silver treatment can be discontinued, and you would then use, so if you were using Biotane Silicon AG, you would then just use your Biotane Silicon. And if you've seen no improvement at all, the silver dressing should be discontinued and consideration given to change into a different antimicrobial agent or systemic antibiotic if that infection hasn't got any better or has got worse. So with your Coloplast 3-step approach to simplifying wound healing, we are hoping that this will make your life easier for you out in practice. So you do your step 1 full holistic assessment of your patient. Use your triangle of wound assessment to assess your wound bed, your wound edge, and your peri-wound skin. Step 2, Robust preparation is key to removing those barriers and creating that optimum healing environment. And your step 3, your treatment, is about your portfolio of dressings to manage your wound of any depth and any stage of healing. So we've talked a little bit today about your step 2, your wound assessment, your step 2 preparation using All Prep Pad, and your step 3 treatment using Biatain Silicone AG if the wound is infected, or Biatain Silicone if it isn't. Now, this is a clinical case study of Mr. D. He's a 55-year-old gentleman that had his left hallux, or his big toe, amputated due to his type 2 diabetes and arterial insufficiency. So there was a problem with his blood supply. Now, this gentleman, in day 1 of this image, they were reviewing whether to go take this gentleman back for further amputation. So he would have lost most of his foot at this point if they had gone back to theatre and continued amputation. There was, as you can see, lots of exudate, and they were struggling to manage that along with infection with this patient. So we did the assessment, holistic assessment of the patient and of the wound, and the management goals for this were to remove the non-viable tissue, manage that exudate, manage the bacterial burden in that wound, protect any granulation and epithelial tissue, and protect his surrounding skin. So we did wound preparation with All Prep Pad, and we treated the wound with Biatain Silicone AG. Now, that wound has decreased in size from 18 centimetres by 7 centimetres to 7 centimetres, oh goodness me, to 4 centimetres by 1 centimetre in 14 weeks. Now, as you can see, that is a huge improvement for this patient. Not only has he managed to keep his foot, but he's actually almost healed as well. And this gentleman did go on to full healing. The top of the wound where the toe was has healed completely in week 14's picture. And the exudate levels to the remaining open area are very low. There are no signs now of localized infection, and the patient's pain score is only 2 out of 10. So the wound no longer requires an antimicrobial to manage that bacterial load, and was then treated with Biatain Silicone. So you see that step down from the Biatain Silicone AG when there's no longer signs of infection or biofilm present in that wound. We can step down to Biatain Silicone. We don't need to use that silver any longer. So we do have a wound healing pathway to simplify your wound healing process with wound infection. And as you can see, this starts with a holistic assessment of your patient, and then the triangle of wound assessment, your wound bed, edge, and peri-wound skin. So we go on to, is the wound infected? If it isn't, we ask if the wound is progressing as expected. If it is, and there is granulation tissue to that wound bed, continue preparation and the treatment plan that is in place. If the wound is not progressing and you're suspecting a biofilm, then you would prepare the wound for healing using wound preparation and consider your treatment objectives. Refer to the wound infection product selection guide and the 2-week challenge with antimicrobial treatment. If the wound is progressing as expected, but there is slough or devitalized tissue to that wound bed, you would prepare the wound for healing using wound preparation such as All Prep Pad, and refer to the product selection guide and apply appropriate dressing. And then if the wound is infected and you see that it is, yes, and it's a local infection, you come down to the wound preparation and your treatment objectives, refer to the wound infection product selection guide and 2-week challenge. So if your wound is locally infected, you would do wound preparation and then you would apply an antimicrobial dressing. If there is spreading or systemic infection, do think about sepsis. This patient needs to have an urgent medical review. They need to have antibiotics, and you may need to refer them to the tissue viability service if this is appropriate at that time. But you also need to do wound preparation and refer to your 2-week challenge with your antimicrobial treatment. no matter which one of these that you follow, you always come back to your reassessment. So you will always reassess that wound and then go back through this. So it's a nice, simple wound infection pathway. If you don't have one in practice, this is a nice, simple one to follow. It incorporates the assess, prepare, treat elements along with your wound triangle of wound assessment. So these are your product selections. So if you've got a superficial wound that is infected, of course, this starts with your wound, your step 1, your step 2 and 3. So your assessment, your preparation and your treatment, the Coloplast 3-step approach. Your preparation will be done with Allprep Pad, and then these are your treatment options. So for a superficial wound that is infected, you would use Biatain Silicone AG, or perhaps you would use Biatain AG non-adhesive if you were using under compression bandaging. If the wound is 0 to 2 centimeters in depth, you could again use Biatain Silicone AG or Biatain AG non-adhesive if you were using under compression bandages. If you're using under perhaps compression hosiery, then you might use your Biatain Silicone AG to hold that dressing in place. If that wound is greater than 2 centimeters in depth, you would use your Biatain Alginate AG and then your Biatain Silicone or your Biatain non-adhesive to secure that. If you've got any undermining or tunneling to your wound, the wound may only be 2 centimeters in depth, in which the Biatain Silicone will be able to conform down to that 2 centimeters. But if you have undermining and tunneling, you do need to fill that undermining, that space with the Biatain Alginate AG, and then you would use Biatain Silicone or Biatain Silicone non-adhesive to secure. So any additional support on our products and services, we're really excited to announce, this is our lovely Georgia, that we're now able to offer you a follow-up telephone call from our specialist team to discuss face-to-face or virtual education with detailed information on our products and services. You can scan the QR code below or click on the link in the chat to submit your details, and one of our team will then aim to give you a call around 24 to 48 hours after this webinar. So please, if you want to know more about products, please do scan the QR code or click on the link in the chat. And then we also here have our QR code for future webinars, which will take you to Coloplast Professional. So we are doing future webinars throughout the remainder of the year, so please come and join us again. And we also do have a podcast whereby we discuss wound healing and how it can be complex, but we like to simplify here at Coloplast using the simplified 3-step approach of assess, prepare and treat. Now we've got 5 podcasts out at the moment, and these are available on all of your podcast platforms, so Apple, Spotify, Google Podcasts, Amazon, and if you just type in Wound Care Conversations, then you can have a listen to the podcast, and hopefully that will help make your life easier out in practice. So that is the end of the webinar today, and I just want to thank you all for joining us this morning. I know you're all really busy out in practice, so I really appreciate that you've taken the time to come and join us, and I hope that this will have made your lives a little bit easier. It will help you to simplify your wound care and your wound healing journey with your patients, especially if they've got wound infection, using the Coloplast 3-step approach of assess, prepare and treat. So I'm just going to go to Sam to see if there's any questions that need answering or any comments before we finish.
Hi Charlie, well done. Great presentation as always. No questions. I've put the link up so that you can contact one of the team to discuss the Allprep Pad, because there was a few people that hadn't seen it or used it, so that will obviously be really useful for them. Lots of thank yous and well done, Charlie, but yeah, great.
Brilliant. Thank you. Thank you all for joining us, and we hope you join us again soon. Take care. Bye-bye.